Good morning, everyone. So we can start today's session. The very first question is about microscopic appearance of glomerulus, and we have to identify that, right? So if you look here, this is all glomerular tissue, right? And on the sides, you can see there is a crescent formation. Clear? So there is a crescent formation, something like this. So this is a classical image of crescentic glomerulonephritis, right? So this is crescentic glomerulonephritis, which is also known as rapidly progressive glomerulonephritis, right? So this is rapidly progressive glomerulonephritis. So the only thing which you need to look here is just look for this crescent type image here, or crescent type impression here, right? So that's very easy, and in this image you can clearly see this is all glomerular tissue, and this is the crescent over here. So it is very easy to identify. It's just that you have to make out the crescent formation, right? So this is all crescent here. Clear? So crescentic glomerulonephritis. And apart from that, you will see some other features as well. One is, of course, the formation of the subepithelial granular deposits. And second important thing is focally flattened podocytes. So the podocytes, something like this, okay? And with the right, so this is the normal podocytes, but what will happen here, the podocytes will become something like this. So this is the flattened podocytes, right? So this is how the podocytes will appear flattened. Then subepithelial granular deposits, it means there will be deposition in these spaces, right? So there will be deposition here, and this is the something like this, okay? So deposition will be here. So this is subepithelial granular deposits. These are few things which you need to remember for crescentic glomerulonephritis. So one is the deposits, then second is the flattened podocytes. Clear? Then we can also see some, obviously the crescent is very well appreciated. So this is all crescent, something like this, right? So this is the crescent, which is made up of fibrin as well. Okay, so just remember these few points, and it is extremely easy to identify an image of crescentic glomerulonephritis, which is also known as RPGN. Clear? So look for this crescent here. So this is the crescent. Fine. So not that difficult to identify. So this is all crescent here, right? So this is the crescent, right? So crescentic glomerulonephritis. Moving forward to next question. A lady presents with fatigue, breathlessness, and pain in the legs while walking. There is neurological deficits, and there is pale sclera and peripheral blood smear is given, right? So fatigue, breathlessness, neurological deficits, pale sclera. Now this is actually suggestive of, you can say, anemia. And if you look at the smear, you can see neutrophils which are having too many number of lobes, right? So if you count here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Normally the neutrophils, they are having the number of lobes which range between 3 to 5. So normal neutrophil has 3 to 5 lobes in nucleus. Clear? But what we are seeing here, there are so many lobes in the neutrophil, and this is known as hyper segmented neutrophil. So the moment you see this kind of presentation, number of lobes more than 5, straightforward jump to the diagnosis of megaloblastic anemia. So what you need to do, identify the WBC neutrophils, count the number of lobes. If it is more than 5, you can make this diagnosis. If it appears normal, then obviously you have to look for other things, right? So one thing is the classical peripheral blood smear. Now this is all, presentation of anemia. And this neurological deficit, it can be the subacute combined degeneration. So this might be this condition, subacute combined degeneration. Okay, so this is how you can make your answer as megaloblastic anemia, right? So always peripheral blood smear is very important. Now let's move on to another question, and here a male has fever, headache and knuckle rigidity. Fever, headache, knuckle rigidity, and this goes in favor of the diagnosis of meningitis. So these 3 points suggest that the person is having meningitis, and therefore for meningitis we will do lumbar puncture and we will send the CSF sample for analysis, and here it is showing a gram-negative diplococci. Now when I say gram-negative, it means the organism will appear red or slightly pink in the smear. So this is gram-negative. Okay, and diplococci, so diplococci. Now here the word diplo means 2, or in simpler words, in pair, and cocci means the rounded forms. Clear? So because cocci and bacilli you must be knowing, right? So this is gram-negative diplococci. Now meningitis caused by a gram-negative diplococci, this is nothing except Neisseria meningitidis. Clear? So the condition which it's causing is there in its name itself. So Neisseria meningitidis, right? And at times we can see that the bacteria is within the neutrophils, that is intracellular, or at times it can be outside the cells, that is extracellular. Okay, so it can be within the neutrophils, that is intracellular, and it can be outside the neutrophils, that is it is extracellular. Now one more important thing, at times in terms of morphology, sometimes they can ask you like, what is the appearance of Neisseria meningitidis? So you can remember it like this, just draw M first and then you can draw the bacterias like this. Clear? So what I want to show you that it looks like half moon. Clear? So the bacterium is like this. So there are two bacteriums and their adjacent surfaces are flattened. Okay, so adjacent surface is flattened. Please remember this because at times it can be asked. So adjacent surface flattened, or the appearance looks like half moon shaped. I'm not discussing about Neisseria gonorrhea because I don't want to mix up the things. So just take one entity at a time. So gram negative diplococci, adjacent surface is flat, half moon shaped. It can be intracellular or it can be extracellular, right? So this is Neisseria meningitis. You can see here the adjacent surfaces are flat. Okay, so this is Neisseria meningitis. Then moving forward to another question, a 6-year-old child and he is having hearing loss, that is deafness, and earache. Now the otoscopic examination image is shown. What is the most likely diagnosis? Now this is one of the easiest question which you can have. Now what you can see here, you can see there is the fluid in the middle ear. Okay, so this is all fluid, and fluid in middle ear, it can be labeled as otitis media with effusion. Effusion means fluid collection. Okay, if you can recall pleural effusion, so there is fluid collection within the middle ear, and that what results in conductive deafness, because the fluid is a bad conductor of sound. So there is conductive deafness, and this is principally seen in children. So we are getting all these keywords here: 6 years old child, hearing loss, and then otoscopy, fluid level. So straight away you can mark your answer as otitis media with effusion, which is also known as serous otitis media or glue ear. Okay, so it is also known as glue ear. So I'm not going into the much details of this entity, but it's just how you need to reach up to the diagnosis, and the otoscopic examination is very easy to identify. Just look for that fluid level, or at times you can have multiple air bubbles in the fluid level, so very easy to identify. So again, if you can see here, this is the fluid in the middle ear, right? So the moment you find the fluid, straight away jump to glue ear. Then identify the agent. Actually this is a gametocyte of plasmodium, one of the plasmodiums. So if you look here, the shape of the gametocyte is somewhat like banana, right? So the shape is somewhat like banana, and therefore if you have these banana shaped gametocytes, you have to straight away jump to falciparum, right? So this is plasmodium falciparum. Clear? So just look for this banana shaped gametocytes. So quite easy to identify. Now moving forward, Woodburger developed a chronic localized lesion over the legs the lesions were irregular and cauliflower like. And when we did the microscopic examination, we found bodies looking like copper coins, right? So here already it has been written like this is copper pennies in a setting of a worker, like he may be a gardener or he may be something related to plants. So there is cauliflower like lesions over the limbs. So this occupation plus cauliflower like growth plus copper pennies on histopathology, this is chromoblastomycosis. Clear? So this is chromoblastomycosis, cauliflower like growth in people dealing with plants or agriculture, and copper pennies. Straight away you can mark your answer as chromoblastomycosis. So you can see these are copper pennies, sometimes also known as medlar body, right? So very easy to identify. Just remember these copper pennies and you will never be wrong in your answer. Then moving forward, which drug can cause this kind of appearance? I think this is one of the easiest answer and everyone can answer this. Now if you look at the limbs, straight away there are toes, right? So straight away there are toes, no intervening thigh or leg. At times we have similarly the things in upper limb. So straight away fingers and all. So that is the classical phocomelia, right? This is phocomelia and this was seen especially with thalidomide. So this is actually a teratogenic effect of thalidomide, right? And teratogenic effect means if a drug is taken in pregnancy, it can result in some fetal malformation. So that is teratogenicity. And when thalidomide was introduced, it was taken as anti-emetic, and then later on it was realized that the babies are getting born with these limb anomalies. So right, that's how it was then withdrawn. So this is teratogenic effect of thalidomide, and it looks like seal limbs. Clear? So it is just like seal limbs, and if you can see here, this is how the seal limbs look like. So this is phocomelia, very easy to identify. Now what type of injury is this? If you look at the margins, they will appear sharp, right? And therefore it might give us an impression as if these are incised wounds, because the margins are sharp. But this is not the case. These are not incised wounds, they are actually lacerated wounds, right? So these are actually lacerated wounds, right? And usually lacerated wounds are something like this, irregular margins. But here, especially because subcutaneous tissue is less, right? In this case, subcutaneous tissue is less, and the skin is directly over bone. Clear? So the skin is directly over bone, and as a result of this, what happens? The lacerated wounds, they have somewhat sharp margins, and therefore we call such wounds as incised looking wounds. Clear? We have to use this word, incised looking wounds. So these are not actually the incised wounds. They look like incised wounds, but in reality these are lacerated wounds, right? So this is a very important concept which one should know, because otherwise the direction of investigation will be on the wrong path, right? So this is not incised wound, because incised wounds, they are caused by sharp weapons, right? And the lacerated wounds, they are caused by blunt weapons. So ideally, if we know this concept, we will search for a blunt weapon. But if we take it for incised wound, then obviously we are going into the wrong direction and we will think of some sharp weapon causing this disease, right? So this is incised looking wound, a type of lacerated wound, and it's occurring on those areas where subcutaneous tissue is less and skin is directly over bone. And what are those areas? Scalp, it can be shin. So any area where there is bone and directly over the bone there is skin. So there we will find incised looking wounds, which are actually the lacerated wounds and are caused by blunt weapons. Clear? So that is incised looking wounds, not to be confused with incised wounds. Now, what is being shown in this image here? So let me highlight what actually is present. So one group is of interest, another is comparison group, right? Then we are taking histories. Okay, so we are taking histories in both the groups, and then finally we are comparing the histories to reach up to some conclusion. Okay, so this is shown in this image, like say group of interest. Now group of interest means actually disease of interest, what disease we want to study. And similar to that, we have one comparison group of healthy persons, right? So this is healthy persons. It means who are not having the disease. So these are diseased, these are normal. Now both of these groups will be given a questionnaire. So we will give a questionnaire and we will ask certain questions regarding the exposure. Clear? Of any type related to occurrence of this disease. And then we will compare the history. Okay. So we will compare, and after comparison we can draw some conclusion about this group, about this group. So this is actually, I think most of you can answer it. This is a classical case control study. Okay, so we are taking case. Now case means the ones who are having disease, and the controls are the one who are not having the disease, they are normal population. So what actually we want to check, like if a particular risk factor, you can take it as risk factor, whether a particular risk factor is associated with the occurrence of disease or not. Okay, so for example, you want to associate, you want to study the association of smoking with carcinoma lung, suppose. So what you will do, you will take one case here, you will pick the patients of carcinoma lung, and then on the other side you will take the normal persons, and that should be comparable of course, and then you will take the questionnaire and you will keep the main point as like, did you smoke? And then based on the outcome, like here you will have majority of the, in this group you will have majority of the people who will say that yes, I smoked, and in this group you will have people who will say that I never smoked. So based on this you will draw the conclusion that this group is having people who smoked, so we can say that smoking is a risk factor for carcinoma lung, and non-smoking is leading to non-occurrence of carcinoma lung. So this is how we do case control study, and since it is in our hand to choose the disease of our interest, so we can usually choose the conditions which are very rare. So we can choose the rare diseases. Okay, so this is a classical flow chart for case control study. Okay, so this is case and this is the control. Fine. So case control study, and we are going into back. So we are going back, and therefore sometimes we always call it, we also call it retrospective study or effect to cause study. Clear? So this is case control study. Now there is one question, like here some calculation is made, and if you see 3 is multiplied by 9, so that is the numerator. Okay, and then 1 is multiplied by 7, and that is the denominator, and then we have a final answer. So what actually is being heard, and on one side you can see exposed, non-exposed. So this is like you can say cross product ratio. So 3 is being multiplied with, so 3 multiplied by 9 and then 1 multiplied by 7. So 39 is the numerator and 17 is the denominator. So this is actually the odds ratio, right? So this is the odds ratio, and we calculate or we derive odds ratio from case control study. Now why I have kept this question, because many times we have a numerical based question, so probably that might help you in that sense. Although image based it won't come like this, it's just to help you in understanding what's odds ratio and how you can calculate in case if a numerical question is there, right? So what we do, we make a group, we make a table of case and control, right? So if we just write it like this, obviously in case control study one group is case, okay, and another group is control. Fine. So this is case and this is control. And as we discussed here, in case control study we go in the past and we ask about the specific exposures. So we will write exposure present and exposure absent. Okay, so case control, exposure present and exposure absent. Then obviously we have certain values like how many persons, how many diseased persons were having exposure. Now just to simplify the things, I'll take lung cancer here. So say this is lung cancer and control is always normal, no lung cancer, right? And then exposure is in terms of say smoking. So people who smoked and who never smoked. So when we will take case, there will be many number of patients who have smoked, and suppose that is A. So A is the number of persons who are having lung cancer and they smoked. Similarly, there will be some persons who smoked but they didn't develop lung cancer. So they smoked. So number of B. So if I just write like A smoked, developed lung cancer. Clear? So that is A. Then there will be some persons who smoked but didn't develop lung cancer. Clear? So this is A and B. So smoked, developed lung cancer, smoked but are normal, hadn't developed lung cancer. Similarly, we will have a group which didn't smoked but still developed lung cancer. So didn't smoked but still developed lung cancer. And there will be one more group which didn't smoked and didn't have lung cancer. Right? So didn't smoked and didn't have lung cancer. Right? So we will have 4 values, and depending on the question you have to put all the values here, and then what you will do, you will calculate the odds ratio. And odds ratio is actually the ratio of this, that is A upon C, to the ratio of this, that is B upon D. Right? So this is the actual formula, but what happens, D will go up and C will come down in simple mathematics. So that is A into D upon B into C. So therefore it looks like as if it is a cross product ratio, but in reality it is A upon C divided by B upon D. Right? So A are the persons who smoked and who have the disease. Right? So A is the persons who are the persons who are smoked and they develop the disease, and C is the persons who didn't smoked, right, but still developed the disease. So sorry, and this is C, right, this is not D, this is C. So the C are the one who didn't smoked but still got the disease. So smoking absent and disease present. Whereas in A, smoking present and disease also present. Clear? So this is how we need to understand the fact. Similarly, B will be persons who smoked but didn't have the disease, whereas D are the persons who are didn't smoke, didn't have the disease. Right? So this is how the odds ratio is calculated. Only what you need to do, you have to make a proper table first, and you have to properly fill the values, and just for simplification, A into D and divided by B into C. So just for simplification, but the main thing is you should know how to make the table first, then your answer will be always right. So A is the one who have the risk factor, who are exposed to the risk factor and develop the disease. B are the one who were exposed to the risk factor but didn't develop the disease. Similarly, C are the ones who didn't have any exposure but still developed the disease, and D are the one didn't have exposure, didn't have disease. Clear? So this is the concept of odds ratio, and obviously you can say that it is derived from case control study. Okay, so this is very important from PSM point of view, especially in related to numerical questions, and many times we have a question based on this particular concept. So I just try to include it in the form of image, but yes, as a image based question it is never going to come. So I am very sorry on that part, but I think if a question comes like calculation based, my job is well done. Clear? So this much is enough for the session, and I am very sure that you might have liked the session. Stay tuned for more. I'll be back shortly. So stay blessed. Bye bye.